starting with the first question, that is regarding the 45-year-old patient with dyspnea, orthopnea, and has a left anterolateral thoracotomy scar and a surgery done 20 years ago. So, is the question age and everything okay in the recall, or is there any discrepancy in this? So usually with the dyspnea, orthopnea, it points towards a mitral valve stenosis, and because it is 20 years ago, it can be a thoracotomy done to repair the valve or doing a mitral valve commissurotomy or repair of the mitral valve. So, okay. Any other changes in the option other than three? Okay, so either okay. So if the option, yeah. So as a surgery has been done through anterolateral thoracotomy scar, usually what I felt from the options and the question that usually when a thoracotomy scar is done or thoracotomy is done, usually it is for a valve repair. And according to this, the best answer I would be suggesting is mitral valve restenosis. Okay. According to the symptomatology as well, usually coarctation is usually done through endovascular repair, but 20 years ago it may also be done surgically. But I feel that it is mitral valve restenosis. But if you guys can help me out with the options or a question properly, then I'll be able to point towards a better answer. Now, coming to the next question, that is a massively enlarged left atrium, and it is a very straightforward. If you see that it is done in mitral valve regurgitation, I think they have asked regarding all MR, MS, AS, and they have asked regarding all the valvular heart disease. So in this, the answer is mitral valve regurgitation. It is a very straightforward question. Then we have a straightened left heart border with the atrial mass effect. So this is again very much straightforward. If you see the Sabiston also, they have mentioned that straightening of the left cardiac border is a characteristic of mitral valve stenosis. So the enlarged left atrium, a characteristic feature of MR. Left straight border is a characteristic feature of mitral valve stenosis. Also from article wherein they are given, there is a straightening of the left atrial or left heart border. So next, that is regarding the least common type of a total anomalous pulmonary venous connection, and this is from Schwartz. That is a mixed type. Okay, it is the least common variety. The most common is the supracardiac. Okay, followed by which you are having the cardiac and the intracardiac at 20-25%, and the least common is a mixed type of TAPVC. Now, this is something which has been wrongly framed according to me, but if you see, it is also DBAKE A in shorthand, that is type 1 aortic dissection. So there is no DBAKE A, it is actually a Stanford A, or it is a DBAKE type 1. So in this, I think if these are the options, usually if you see the DBAKE type 1, it involves the arch and the ascending as well. So there is no one answer according to me. It cannot be arch or ascending. If it is a DBAKE type 1, which involves the ascending aorta. Okay.
Yeah. Okay. Yeah. So I think there was an option of ascending and the arch of aorta. Okay. So yeah. So if you see the type 1 or DBAKE type 1 or Stanford type A, and it involves the ascending and the arch of the aorta. So according to that, that would be the best answer. But this was, I think, a typo or a wrongly framed question. So moving on to next, that is the pathophysiological mechanism of aortic valve regurgitation in patients with VSD. I think this was a figure which was given. I hope the question is okay in this. Yeah. So this is a very straightforward question, that this is a typical Venturi effect, and that is commonly seen with a VSD, which leads to a aortic valve regurgitation. So if you want to understand, the basic thing is that whenever there is narrowing, the blood flow, it causes increased pressure before and after, and there is a decrease in the pressure near the area of narrowing, and which ultimately, because of this, it causes increase in the fluid velocity, decrease in the pressure, and this low pressure zone impacts the aortic valve and it leads to a aortic valve regurgitation. So that is the answer here, Venturi effect. Next, left atrial enlargement with LVH and a ST depression noted on ECG. This is a direct straightforward question which has been framed from Bailey, and this is the answer is aortic stenosis. Okay. Because of the stenosis, there is a left ventricular hypertrophy, and with that, there is a LV strain pattern. Okay, because the left ventricle is trying to push against resistance, and that is what leads to ST depression. Okay, next, I think the image would be different, but I think there was an image of stent placed in the aorta. As the image of X-ray was the X-ray image given, or there was other image? I think these are a very straightforward question. I think if the stent is in the aorta, it would be coarctation of aorta. There would not be any tracheal stent. Okay, yeah, right. Okay, so if this is the image with the position of the stent as shown here, it is most likely in the aorta and it would be a coarctation of aorta. I think these are not the options. Where these are options? Okay, if the X-ray was only given, and what were the other two options? I think other than coarctation and tracheal stent, there would be some, I think, two other options. So was the diagnosis asked or the location of the stent asked? I think the options were this, that is coarctation, tracheal stent, esophageal stent, and the stent in the vertebra or a spinal column. Okay, so this is a very straightforward, that it is mostly in the aorta. The esophageal stent would not be like this or a short segment. Usually it is a long segment stent. And if an X-ray is done with the position which is seen near the lung border, it would be in the aorta. So that would be the correct answer here. Okay, so percutaneous stenting is a current standard. Now, I think this was the image given, that is a patient with history of smoking with the following finding of clubbing and periostosis. So I hope this was the image given. Yeah. So if this is the image, I think there is, if what are the findings is asked, it is usually hypertrophic pulmonary osteoarthropathy. Okay, yeah. So this is associated with SCC, but it is the hypertrophic pulmonary osteoarthropy. And if the image is given, then the answer would be a hypertrophic pulmonary osteoarthropathy. Okay, so if it was both hypertrophic pulmonary osteoarthropathy and a small cell carcinoma, yeah, that would be the correct answer. This is a very straightforward question from Schwartz. I think they have taken a lot of them from Bailey and Schwartz rather than Savaston. That is what I felt in CTVS. Next question, that is a patient with a fever, productive, foul smelling. Was HPOA given in the options or not? What were the options for this question? Yeah, if it was given, that is the answer. Yeah, okay. So next would be a patient with fever, productive, foul-smelling cough with chest X-ray showing some cavitary lesion with air fluid level. Again, I think they have taken straightforward direct image from the Schwartz. No, the aspergillosis question is like other question, that is monads, and I think this was a different question. There are two questions from the same almost 2-3 pages. If you rotate in Schwartz, they have asked. So if this was a question with the image which is given, that is for lung abscess. Okay. To move on to next, that is the characteristic monad sign which is given. Okay. Now this is for aspergilloma. This is again, I think this was the same X-ray which was asked. So the one answer is lung abscess, the other is aspergillosis, again taken from Schwartz directly. Next, again from small lung cell, given in CT what? I think both questions are fine, right? The images and the options. So moving on to next, that is regarding the hyponatremia as a paraneoplastic syndrome associated, again, a very straightforward, again taken from Schwartz, that is small lung cell carcinoma. So Moving on to next, that is SRE technique used for foam sclerotherapy. What is the correct ratio of sclerosant to air? I think there was a discussion regarding sclerosant to air or air to sclerosant. Remember, there is always more of air than sclerosant. So if you see, it is always a 1:3 or 1:4 ratio of sclerosant to air. So if the question was sclerosant to air, it should be 1:4. If the question was air as to sclerosant, it should be 4:1. I think there is no query in this. Regarding the hyponatremia, can you confirm what was the question? Is it correctly given? That is presenting with hyponatremia and a paraneoplastic syndrome given in what? I think this was the question, right? So moving on to next. That is regarding foam sclerotherapy. I've already discussed. If it is whatever it is, it should be either 1:4 or 4:1 according to the question wording. Sclerosant should be 1 and air should be 4. Next, that is a patient with claudication in thigh and calf pain, and pulses in opposite limb are normal. What is the site of arterial pathology? So this is again a very straightforward question, that is regarding the claudication in thigh and calf, that is history of iliac obstruction, and it is always mostly external iliac, not internal iliac. External iliac further goes in and converts into femoral, and that is how it supplies the limb. So the answer here is external iliac stenosis. So if SIADH scenario was given in this with paraneoplastic syndrome seen in which carcinoma also, the answer should be small lung cell carcinoma. Next, most common wound complication of standard varicose vein surgery. Again, a very straightforward question from Bailey, which is wound infections are the most common complication of standard varicose vein surgery. And if you ask for the serious complication, it is nerve injury. Okay. Now, most common see, what was the question asked? If it was the most common complication of standard varicose vein surgery, it is wound infection. And if the question was most common serious complication, then okay, the second option was nerve injury. Okay, fine. So the answer here is wound infection. Next, most common cause of reintervention after TEVAR, most commonly it is endo leak. Okay. So again, I could not find reference from the 3 books. So I searched the literature, and in the article, usually this is a multi-center study in which they have found that most common indication for secondary intervention was endo leak. So that is the answer here. A picture of Klippel Trenaunay syndrome, most appropriate next step is asked. So if you go by Bailey, it is usually treated conservatively with compression followed by surgery. That is usually laser ablation of the nevus. So are the options correct in this? For the TEVAR question, if you have any other reference, do share with me. I'll also cross check and I'll confirm what would be the answer. Okay. So the fourth option would be Doppler to rule out DVT in reflux, EBLA for superficial veins. Was the patient treated conservatively first in the question? Can you guys please confirm so that we can be sure of the question and the answer in this? Okay, so I think there is some discrepancy. Yeah, conservative first was an option, so that would be the first. That would be the answer here accordingly. MR venogram usually not done. EBLA is not done for superficial vein. It is actually for the vein nevus, not for the superficial vein. And Doppler usually in Klippel it is due to hypoplasia. Doppler will not help according to me. So the answer would be conservative first option. Yeah. So next 4-layer compression bandage exerts which layer exerts the maximum pressure? So if you see in Bailey, I think the venous questions are all from Bailey. So the cohesive bandage, elastic is giving 1/3 of the pressure, whereas cohesive gives 2/3. So according to here, the answer would be cohesive bandage. Okay. Elastic will give 1/3 band pressure and cohesive will give 2/3. So that would be the answer here. Next, pseudoclaudication is a very straightforward question. I think popliteal artery, femoral artery will not give pseudoclaudication or also neurological claudication. So this is again a very straightforward, easy question, that is lumbar canal stenosis or a spinal canal stenosis. Next, patient with atrial fibrillation, gangrenous strokes, most likely diagnosis. Again, I think this is from Bailey, which is showing that usually embolus will be from left atrium in atrial fibrillation or left ventricular mural thrombus following MI, or vegetation in infective endocarditis or thrombus in aneurysms. According to here, the answer would be the embolization from left atrium causing a ALI. Okay. So that is the answer here, and I hope the options and everything is fine in this question. Moving on to next, I think this was the image or something like this, wherein the gallbladder is arising from the dilated duct. So this is again a okay. What were the options? What was the fourth option? I think it is answer is type 1A. That is clear. But what were the options here? 1A, 1C, 4A, and what was the fourth option? Or are the options correct in this? So it is not type 2. Type 2 is actually diverticulum. Here, this gallbladder is arising from the dilated duct. Yeah, I think the picture would be wrong, but I think it was type 1A, which was there in the question. I think the picture was something like this, right? The gallbladder arising. I think majority of you were discussing regarding gallbladder is there. Okay. So I think it would be a 1C option and answer an image. So I think this would be 1C. So I think again I'll reconfirm this. You guys can send me the reference photo, whatever you have. So we'll confirm with this. So I think the liver segment image, I think this was directly taken from Sabiston, which is they wanted to ask segment 4B. I think this was the image. So this is again a very straightforward, that is segment 4. I think there is no discrepancy in this. I think this was the image. So the colorectal cells, don't worry, I'll reconfirm. There are a few questions which will be there in each session. So I'll just I'll recheck and I'll confirm in the final session. So I think this was the image, right? Please confirm. So again, a very straightforward question. It is segment 4. Yeah. Then which of the following gallbladder polyps has low malignant potential? So this is cholesterol polyp less than 1 centimeter. If you see Bailey cholesterol polyposis, only advise if there is diagnostic dilemma. Otherwise, they are not. Next best step for Klippel is not to do MR venogram. I feel it is a conservative therapy, but again, you guys can confirm the option, so I'll be correcting that. So if you see polypoidal lesion amongst the question, I think this was, yeah, okay. So this is a very straightforward that it would be type 3A, Bismuth call it, okay. So this brings an end to this session for now. So I think one or two questions I think I'll reconfirm with you guys and I'll cover in the next session. So that's it for this session. Now remain